This particular project, which I carried out with a co-author, Sally Williams, was focused on productivity in NHS hospitals. The focus on hospitals is because, of course, they account for the bulk of spending in the NHS, and also they have been the source of most of the productivity decline that's happened in the NHS over the past 10 years or so. So there's a lot of room for improvement. Now, the way we went about the project was, it really had two prongs to it. Firstly, we carried out a review of international literature on sources of gains in efficiency in hospitals. And secondly, we carried out a small survey of senior managers in a sample of NHS trusts which appeared to have been able to increase their efficiency without reducing quality following the period when a lot of NHS hospitals got into financial difficulties around 2006. We spoke to quite a lot of managers about their experiences, how they'd managed to turn around their hospitals. Well, we found it useful to divide them up a bit into external factors that either helped or hindered improvements in efficiency in hospitals, and internal factors within the hospitals themselves. And the second set of factors we subdivided into, I suppose, what you might call human factors, such as leadership, good management, and the rate at which, I suppose it's mainly clinical staff, are adopting new technologies. And also, the second category we looked at were actual changes to operational processes. For example, increasing the proportion of surgical cases treated by day case surgery. In the case of the external factors, we found quite a few factors which seemed to predispose towards efficiency. They included financial pressure, both in Britain and in the United States. Historically, when governments have put financial pressure on hospitals in America, it's Medicare we're talking about and Medicaid, they seem to respond by improving efficiency. And when the pressure's taken off, productivity often deteriorates. Another set of factors we found was associated with improvements in efficiency was technological change, the availability of technological change. And a third set of factors was what I think I would call certain institutions associated with the second internal market in the NHS. By that, I mean the reforms that happened under Prime Minister Blair and Health Minister Milburn, which involved, for example, increasing competition in the NHS and also payment by results, paying hospitals by patient case. Turning to the internal factors, we found quite a lot of evidence that management, good management, leadership, and the rate at which technology was adopted had effects on efficiency. And similarly with hospital processes, there's a list of factors we've put in the report that were favourably associated with efficiency. I expect everybody thinks that leadership and good management are associated with high performance in organisations, but what I think is interesting now is that evidence has emerged from case studies and from statistical analyses that certain aspects of leadership and management, certain aspects of management are associated with high productivity. For example, there is evidence that if managers set targets for staff and monitor their performance against those targets and reward good performance, that is reliably associated with higher productivity. And there's evidence both from firms in the wider economy and from hospitals, including NHS hospitals, to that effect. We found they were highly complementary. There's a whole bunch of studies, mainly from America, we came across, which suggested statistically that high quality, to the extent that can be measured, and efficiency are positively associated. What's not clear is the reasons for that. One possibility is there's a direct association. High quality leads to high efficiency because getting things right first time enables costs to be saved, for example. But it's possible that the relationship is an indirect one. That is that hospitals which exhibit high quality and efficiency are well-managed hospitals and hospitals where the available technologies had been adopted more rapidly than other hospitals. Of course, it could be a combination of the direct and indirect effects. Well, I think that staff productivity is very important because hospitals are labour-intensive organisations and 65 to 70% of costs are down to staff. So that's where you're almost bound to look first if you are confronted with the need to make important efficiency gains. And the managers we spoke to, a lot of them mentioned that controlling staff costs was very important to the favourable changes that had happened in their hospitals. And it's not just a matter of downsizing the workforce, although that is obviously an aspect of it, but it's also a matter of encouraging your existing staff to be as productive as possible. And we found quite a lot of enthusiasm for methods of encouraging staff productivity in the managers we spoke to. There are quite a lot of practical suggestions that came out of the work, especially in the interviews we had with senior managers. And I guess that quite a lot of managers would say that making major productivity improvements is a matter of lots of small things rather than big things. But if I was to pick out three things which particularly stick in my memory, I would say, well, there are some old favourites, such as reducing length of stay and increasing the proportion of surgical patients treated by day surgery. And another set of practical techniques which we found met with approval were what I think is called lean production, the productive ward and the productive operating theatre, and ideas such as that, which above all involve engaging staff in looking for ways of improving patient pathways, improving quality, eliminating waste. And lastly, I think I would mention the fact that quite a few managers were very enthusiastic about involving their staff in thinking about improving quality, the quality of care, and very often, such as reducing hospital-acquired infections. And the savings come tumbling out of that.